Hello and welcome to our next unit, immunology. We're going to go ahead and talk about the interaction of body components to fight disease and infection. So let's get started. When talking about immunology, there's a few terms you want to be familiar with, and the first one is immunology itself, and that is the study of systems responsible for the disposal of foreign material. And those are things that the body determines as one, not oneself or non-self. Serology is the study of diagnostic procedures connected with resistance and immunity. Antigen and antibody reactions are noted in vitro. And so basically what this is saying is serology is the laboratory testing typically seen on patients' serum for antibody. Our first line of defense are our natural barriers of intact skin, the mouth, the respiratory tract, the GI tract, the vagina, and the urinary tract. So for example, some first natural barriers of the skin would be things like sweat, lysozyme and fatty acids, and also sloughing off of epithelial cells and sebum. Sebum, of course, is an oil on the skin that has antimicrobial properties. Then there are components of the mouth, such as mucous membranes that trap organisms, and it's one of the natural barriers of the mouth. Saliva is in the mouth, and saliva contains lysozyme and IgA antibodies. Also, the mouth is slightly acidic, and there is a shedding of epithelial cells in the mouth as well. Plus, there's normal flora of the mouth. In the respiratory tract, we have the movement of mucus. We have sneezing and coughing and nasal hairs, which filters the air we breathe. We also have closing of the epiglottis when swallowing, and that prevents stomach organisms from going into the respiratory tract. And then we have normal respiratory flora of the upper respiratory tract. In the gastrointestinal tract, we have acidity of the stomach. Usually the stomach has a pH of about 1, and there are very few organisms that can survive that pH. The small intestine contains enzymes like digestive enzymes such as peptidase and macrophages. There's also normal intestinal flora, and the small intestine is in constant motility, and that's called peristalsis. Then we've got the acidity of the vagina. The acidity of the vagina is about 5.0 due to the presence of lactobacillus, and most organisms can't survive that slightly acidic environment. And finally, we have the urinary tract. Urine itself should be sterile, but the urinary tract is also acidic, and there's the mechanical washing effect of urine, and it prevents skin organisms from entering the urethra or the urinary tract. There are other natural barriers, not necessarily body systems, but they also contribute to our first line of defense. And some of those natural barriers would include tears. Tears contain lysozyme, and lysozyme is a chemical that destroys the gram-positive cell walls of bacteria. And tears also contain the antibody IgA. We have our body temperature. Not all organisms will grow at 35 to 37 degrees Celsius. We've got oxygen tension. Anaerobes may be inhibited in areas like superficial wounds, but be normal in the gastrointestinal tract. We've got age. Infants' immunity is not fully developed, whereas the elderly immune system is not very efficient and is starting to break down. We've got cortisone levels. This is an adrenal hormone, and it decreases the inflammation response. We've got earwax, which protects our auditory canals of the ear. We have interferon, which is a protein released by white cells that inhibits viral replication. And then we have serum bacteriocin, which is also known as beta-lysine. This is a compound in serum lethal to bacteria, and it is a protein produced by bacteria that kills other closely related bacteria. It's actually more potent than antibiotics, but less broad spectrum. And these are just a number of other natural barriers that we have to protect ourselves from infection. There are a number of other contributing factors when it comes to catching a disease or illness, and those would include things like diet, metabolism, whether we've been exposed to toxins or if we've had an allergic reaction, our stress levels, hormone levels, and nutrient levels. These all play a role as to whether or not we're going to develop a disease. So for example, diet is important in our growth and development as well as immunologically. Phagocytosis and cellular and humoral immunity is affected by diet. So if you have a protein deficiency or your carbohydrate levels are out of whack or your lipid levels are out of whack, Even if you have a deficiency in vitamin or minerals, this leaves us more prone to developing an infection. Metabolism is the sum of all physical and chemical changes that happen within an individual. A problem with a person's metabolism may make them more susceptible to diseases. Okay? There are toxic effects of certain substances, or a person may have allergic reactions, which lowers one's resistance to infections. You could have side effects to things like nitrates, which is a type of salt found in your foods, nitrites, which are nitrates broken down to be used to dilate blood vessels and lower blood pressure. These things can actually be toxic or cause you to have an allergic reaction. Same thing is true with additives in foods and some of the chemicals produced during the cooking process of certain foods. Hormones can affect one's immunity as well. The production of hormones can be affected by stress. So, for example, a lack of sleep will actually increase your stress-related hormones, and a lack of sleep plus stress equals a low number of T cell count, or your natural killer cells will be imbalanced. So hormone imbalances can contribute to a person's resistance to disease. So in summary, for a disease state to develop, a microorganism or virus must be able to evade and overcome our body's immune system. Okay, and this is an immune system that's normally operational. Our first line of defense from preventing disease are the components of the skin, respiratory tract, gastrointestinal tract, and urogenital tract. Let's talk about our second line of defense, which is inflammation and phagocytosis. This is a function of monocytes and macrophages in host defense. Both cells are phagocytes. Okay? The monocyte is loosely considered to be an immature macrophage, and the monocyte is in the peripheral blood and the macrophage is in the tissues. When inflammation and phagocytosis occurs, this is an immediate response. Phagocytosis is the ingestion and digestion of microorganisms and debris. This is all enhanced by an antibody known as IgG and complement, which is a series of plasma proteins. During inflammation, the objective is to localize the irritant and eradicate it, and also to repair the tissues. However, inflammation does increase phagocytic activity with a series of biochemical and cellular changes, but tissue damage could result in inflammation. Some signs of that inflammation and the phagocytic process has occurred would be pain at the site of injury, heat at the site of injury, redness, and swelling. Inflammation involves several different things, including capillary dilation, plasma protein escape from the bloodstream, and leukocyte accumulation at the site of injury. So like I said in the last slide, inflammation involves capillary dilation, plasma protein escape from the bloodstream, and also leukocyte accumulation at the site of injury. Guess we already covered that in the last slide. So the mechanisms involved in inflammation and phagocytosis are both cellular mechanisms and humoral mechanisms. Cellular mechanisms include T cells and the phagocytic cells. The humoral mechanisms are the non-cellular components such as antibodies and complement. This plays a role in opsonin presentation in cellular immunity. It prepares the pathogen to be fully engulfed by the phagocyte. An opsonin is a substance that binds to foreign cells, making them susceptible to phagocytosis. So how does the body respond to an injury or an infection? Well, there's increased blood supply to the injured area, and these mediators cause capillary and venular dilation. There's increased capillary permeability, migration of white cells from capillaries to the surrounding tissues, and specifically that's the macrophages. And then again, it is the migration of macrophages. So its inflammation response is directly proportional to increased phagocytic activity. The more inflammation there is, the more phagocytic activity there is. The less inflammation there is, the less phagocytic activity there is. There are several steps in inflammatory response, including dilation of local arterioles and capillaries. This will actually increase blood flow to the site of infection. Edema fluid accumulates in the area of the injury, and there are increased proteins in our fluids. fibrin forms a network inside the lymphatic channels, and this limits bacterial spread. Chemotaxis is when cells move to the area of injury under a chemical signal, and it's usually the neutrophils that arrive first. They usually arrive to the site within an hour. Tissue macrophages are already at the site. Phagocytes then engulf and digest bacteria, and the toxins are then disposed of. And then the white cells become lysed, and that's called apoptosis, when a white cell actually commits cellular suicide after doing their job. Macrophages are activated and engulf the lysed white cells and bacteria. And then finally, at the very end, inflammation becomes resolved. The T helper cells stop emitting the stay alive signal to the white cells. So phagocytes are cells that engulf bacteria. We've got the polymorphonuclear leukocytes. Those are also known as pus cells or neutrophils. We've got our monocytes, which are monocytes that are circulating macrophages. And then we have the fixed macrophages of the mononuclear phagocytic system. Now, not all bacteria is susceptible to phagocytosis. Some bacteria can actually resist phagocytosis, and they do this in three ways. They have capsular material, and that would be things like Pseudomonas and Streptococcus pneumonia that actually have a capsule, that glycocalyx material, and that capsule prevents bacteria from being phagocytized. There are certain organisms that produce what's known as a VI antigen, which is an envelope antigen, or an envelope antigen on the surface of some bacteria that makes it resistant to phagocytosis. And then we have toxic enzymes and other toxic substances that bacteria use to resist phagocytosis. For example, in Streptococcus group A, one of the toxic enzymes that they have is streptokinase. And then other toxic substances that you may have heard about in this class would be leukocidin, which is a chemical produced by Staph aureus that is actually deadly to other bacteria. So here's a list of several organisms that resist bacterial phagocytosis, and there's a number of different ways they do this. Streptococcus pneumoniae has a capsule. Staphylococcus aureus produces leukocidin, which is a toxin released by some bacteria that kills leukocytes. We've got Streptococcus group A. It produces streptokinase and streptodornase, which are toxic to phagocytes. We've got Neisseria meningitidis, which has a capsule, as well as Klebsiella pneumoniae, which has a capsule. We've got Salmonella typhimurium, which has the VI antigen, which is an envelope antigen. Haemophilus influenza that has a capsule. And finally, we've got Streptococcus group B that produces exotoxins and also has a capsule. So these are just a few examples of bacteria that can resist phagocytosis and a few ways that they can go about resisting phagocytosis. Sometimes when you have an infection, you develop a fever, and this is a physiologic response to an infection. This is the body's immune response attempting to neutralize bacterial or viral infections. And this can be caused by exogenous pyrogen or endotoxins of gram-negative rods, and that is present on bacterial cell walls, or it can be caused by extracts of leukocytes. Chemicals released by the granules of white cells can affect the brain's hypothalamus. That's the body temperature set point area that actually is increased. A fever is actually going to increase mobility of your leukocytes, enhance phagocytosis, diminish endotoxins, those are bacterial endotoxins. A fever will also increase T cell proliferation, and a fever will also enhance activity of interferon. So phagocytosis and inflammation is our second line of defense. And phagocytosis happens in a series of different steps. And those four steps are called chemotaxis, opsonization or attachment, engulfment, and digestion. Chemotaxis is the first stage in phagocytosis, and this is when cells move towards the injured site via stimulation of chemicals. So it's moving towards a chemical signal. And by the way, neutrophils are very actively motile, and so they're going to be the first to arrive at the site. There are chemicals that initiate chemotaxis, and those chemicals are chemotaxins, leukotaxins, and certain components of complement. When organisms are coated with materials that speed up phagocytosis, these uh, things are called opsonins, or this is called opsonization or attachment, which is the second stage in phagocytosis. Phagocytes then go through the endothelium and snuggle up next to the bacteria and then attach. The opsonin promotes attachment of phagocytes, and usually an opsonin is something like a receptor on a neutrophil or a C3 component of complement. These are all opsonins. Serum proteins help phagocytes attach also. Serum proteins that help with phagocyte attachment would be C-reactive protein, complement, which is a series of proteins in plasma, and antibodies. Engulfment is the third step in phagocytosis. This is also known as active membrane invagination. What happens is phagocytic cell cytoplasm flows around the engulfed cell and fuses to itself. Here it becomes a phagosome. When the bacteria is surrounded by the entire cell, this is called a phagosome. Bacteria must be more hydrophobic or water-fearing than the phagocyte to be engulfed. The fourth step of phagocytosis is called digestion, and this is the intracellular event of killing and digestion. Phagocyte granules will release hydrolytic enzymes, and such enzymes would be things like lysozyme, lactoferrin, and myeloperoxidase. Lactic acid increases inside of the cell. Lactic acid increases, which lowers the pH to 4.0 or less inside the cell, and this is lethal to most bacteria. Hydrogen peroxide or superoxide is then produced. The production of hydrogen peroxide aids in killing bacteria at this time also. Then the neutrophils die and are phagocytized by macrophages. Our third line of defense is the production of antibodies. First, you need to know a few terms. An antibody is a protein found in body fluids. It's an immunoglobulin formed to combine with an antigen and neutralize its effects. Adaptive immunity is when the third line of defense has kicked in, and this consists of both cellular and humoral components. It allows the body to recognize, remember, and respond to an antigen. Antibodies are generally all similar in nature except a small region of the tip of the protein, which is extremely variable. Each of these variants can bind to a different antigen. Antibodies contribute to immunity in three ways. It prevents pathogens from invading by binding to them. It stimulates macrophages, and it stimulates the complement pathway. The antibody response leaves the host with an immunological memory. Thus, the host can immunologically respond to antigenic substances quicker the next time. It allows the host to respond quicker to problems. The primary antibody response and secondary antibody response are described as IgM and IgG response. IgM antibodies are made to a first exposure to an antigen, while IgG antibodies are made upon a subsequent exposure to an antigen. There are four phases of antibody response that take place when we're exposed to an antigen. The lag phase, where there's no detectable antibody in serum. The log phase, where the titer starts to rise. The log phase is where the antibody titer starts to rise logarithmically. The plateau phase, where the titer stabilizes, and then finally the decline phase, where the antibody is catabolized and the antibody is destroyed during this metabolism. There are 5 antibody classes: IgA, IgG, IgM, IgD, and IgE. And the first antibody to rise during a primary antibody response is called IgM. This response occurs in the acute phase of any disease. So it responds after an acute exposure to an antigen, and this depends a lot on the individual and the specific antigen exposed to. Usually 5 to 15 days later, there's detectable antibody in serum. The lag phase is fast. This is a latent period that lasts a few hours to many days. It's actually slower than the secondary response. The log phase is when you see a sharp rise in IgM. The plateau phase is when the IgM stabilizes, and then there is a sharp decline of IgM when the patient starts to respond. During a secondary antibody response, the predominant antibody formed to secondary stimuli is IgG. The T memory cells stimulate this antibody production. This response occurs in the convalescent stage of the disease, and some IgM antibodies may be present here, but they're in very low amounts. Most of the time, you see primarily IgG. The lag phase is slow, and the rise is 1 to 3 days later, and it's actually faster than that of the primary response generally. The log phase, you'll see a fast rise. The plateau phase remains high longer than in a primary response, and then you'll see a gradual decline of IgG as the patient starts to get better. In this image, you can see the difference between a primary and a secondary response. A primary response takes longer for lag to happen than in a secondary response. Both primary and secondary response show a sharp or rapid rise in the log phase. In the secondary response, the plateau remains higher longer than in the primary response, and in the primary response, the decline is sharp, but in the secondary response, the decline is gradual. In this table, what I've done is I've tried to compare a primary to a secondary antibody response. You can see that in a primary response, the time for antibody to rise after exposure to an antigen is about 5 to 15 days, whereas in a secondary response, it occurs much quicker at 2 to 4 days. The major immunoglobulin detected in a primary response is IgM, while the major immunoglobulin detected in a secondary response is IgG. The amount of immunoglobulin in the titer in the serum in a primary response is low, while you have a much higher titer in a secondary response. And then the duration of the titer will be short for a primary response and long for a secondary response. Glycoproteins or gamma globulin proteins or immunoglobulins are synthesized by B cells. They can be found in tears, saliva, blood, and plasma, and they're used by the immune system to neutralize bacteria and viruses. The B cells become either antibody-producing plasma cells or they become memory cells, a long-lived lymphocyte capable of responding to an antigen on its reintroduction long after the initial exposure that caused its production. And again, antibodies can be found in mucous membranes, usually that's IgA or IgE, serum, that's mostly IgG, saliva and tears, which is IgA, and breast milk, which is mostly IgA. Here's a nice example of a monomer immunoglobulin. This happens to be immunoglobulin G. If you take a look at the diagram, you can see the long chains, which are called the heavy chains, the small short chains, which are called the light chains, and you can see that there's a series of amino acids that are colored in red. Those are the variable regions, and then on the heavy and light chains, the series of amino acids at the bottom in the colorless section is called the constant region. Okay, so this is an example of a nice monomer, but sometimes antibodies can be monomers. They can be dimers where there's 2 molecules put together. They can be pentamers where there's 5 molecules put together. Okay, but for the most part, most of our immunoglobulins are monomers. There are 5 classes of antibodies recognized in higher mammals, and they're named after their heavy chain. We have IgM, IgG, IgA, IgD, and IgE. That stands for mu, gamma, alpha, delta, and epsilon. These are the 5 major serum antibodies, and the most abundant in serum is IgG. Let's go ahead and talk about the types of immunity. We have what's called natural resistance or non-susceptibility. Natural resistance or non-susceptibility includes species characteristics that provide absolute protection against certain diseases. For example, man is not susceptible to certain animal pathogens. Okay? Then we have natural immunity. Natural immunity is immunity you're born with, antibodies that are present without external stimuli, and it may be affected by a person's heritage or race. Levels of antibodies are low and not passed via the placenta. Okay? We have acquired immunity, and we have both passive acquired immunity and active acquired immunity. Passive acquired immunity is developed immediately and lasts temporarily, like weeks or months. It is transferred from the fetus or to the fetus from the mother, like IgG antibody, and it may be produced by injections of gamma globulin or antisera. Active acquired immunity is the resistance level is built up in this situation. And this happens following an exposure to a bacterial or viral illness. This immunity lasts for years, and it occurs from actual infections or for an inoculation of a vaccine. Then we have cell-mediated immunity. It is a protection of sensitized T cells or production of sensitized T cells. And we have humoral immunity, which is when B cells are sensitized and they produce antibody. Here we have a table that compares humoral immunity versus cell-mediated immunity. In humoral immunity, the mechanism is antibody-mediated. The cell type is B cells. It's B cells that actually come from the bone marrow and lead to the production of antibody. The mode of action is antibodies in serum or other body fluids, and the purpose is defense of some bacterial or viral illnesses, so it has a prophylactic effect on the body. In cell-mediated immunity, the mechanism is cell-mediated, and the cell type is T cells. Usually those are lymphocytes. And the mode of action is cell-to-cell contact or soluble products from cells like interleukins and other cytokines that digest pathogens. And then finally, their purpose in cell-mediated immunity, or its purpose, is defense of viral, fungal, intracellular bacterial infections, tumor antigens, and graft rejection. Here's a table that compares active acquired immunity versus passive acquired immunity. In active acquired immunity, the source is self. So in other words, you've been vaccinated or you've had the disease. In passive acquired immunity, you have gotten the antibody from another human or animal. So in other words, it's come from the placenta of mom, or you've been given gamma globulin or an antitoxin. The effectiveness of active acquired immunity is high, while the effectiveness of passive acquired immunity is moderate to low. The mode of acquisition for active acquired immunity is that you've had the disease or a vaccination. The method of acquisition for passive acquired immunity is placental transfer, breast milk, or an injection of gamma globulin. Active immunity, it takes about 15 days to develop, whereas passive immunity, you develop immunity immediately. When you have active acquired immunity, if you've had the disease or vaccination, the duration of that immunity lasts a long time, while in a passive acquired immunity situation, the duration is much shorter, weeks to months. The use for active acquired immunity is prophylactic, so you don't get the disease at all, whereas passive acquired immunity is also prophylactic, but it has a therapeutic use as well. So, for example, you could use a passive amount of IgG or gamma globulin to protect you from an exposure to something like hepatitis. Let's go ahead and switch gears and talk about antigens. Now, antigens are different than antibodies, okay? An antigen is a protein marker on the surface of a cell that identifies the cell as self or non-self. So the body's immune system, when they come in contact with these protein markers on bacteria, they identify them as non-self. Whereas if they come in contact with other white cells, they would see those markers and call that self. An antigenic determinant is also known as a combining site or epitope. It is structures or molecular components on the membrane of a cell that are recognized as foreign. A determinant group is sites on or within an antigen in which antibodies will react. The number of these sites is its valence. So antigens are multivalent. They have many combining sites which antibodies can react to. There are a number of antigens that are clinically important. For example, the human leukocyte antigen, also known as the HLA antigens, are part of the major histocompatibility complex that mediates interactions of white cells and other cells. The HLA antigens include histocompatibility antigens or tissue-compatible antigens, and they are present on nucleated cells. Not just leukocytes, but they are on tissue cells and other leukocytes as well. Autoantigens are self-antigens that produce autoantibodies. Blood group antigens, these have properties that make them good antigens. Microbial antigens are on bacteria, viruses, toxins, and toxoids. So there are certain physical and chemical properties that make something an antigen. For example, an antigen has to have a high degree of foreignness. So the degree the immune system recognizes the antigen as self or non-self. Some things the immune system sees as foreign and other things it recognizes as self. Degradability. The molecule must be present long enough to trigger an immune response. If it degrades too fast, then it can't be an antigen or won't be antigenic. Molecular weight. Antigens have a high molecular weight of greater than 10,000 Daltons. Okay? Structural stability. If a molecule is structurally stable, it could be a good antigen. Complexity. The more complex the antigen is, the more effective it will be in eliciting an immune response. And finally, if the molecule is a protein or large polysaccharide molecule, it's going to make a good antigen. We have three primary types of antigens: autoantigens, alloantigens, and heteroantigens. An autoantigen is a self-antigen and triggers autoantibodies. An alloantigen is a foreign antigen from the same species, for example, blood group antigens from donor cells. A heteroantigen is a plant, microorganism, or chemical antigen. It's an antigen not originating from one's own body. So you might be asking yourself at this point, what exactly is a role of an antigen? In other words, what's the criteria which an antigen must fulfill? What is the criteria which an antigen must fulfill? It must induce the formation of antibodies or immune lymphocytes, and it must react specifically with the antibody or cell that caused it to be produced. One way to have actively acquired immunity is by being vaccinated. So let's talk a little bit about vaccines. Vaccines are made from the following: killed organisms, for example, Bordetella vaccine, the measles, mumps, and rubella vaccine. Those are made by using killed organisms. Altered live agents, also known as attenuated agents. These are exact antigens from non-dangerous strains. We have detoxified toxins, also known as a toxoid. One type of vaccine that is made from a toxoid is the tetanus vaccine. This is basically a toxin that's been treated with acid or heat. They stimulate antitoxins in the body. And then finally, the last type of vaccine that can be made is one that's made from fractionated materials. This is a vaccine that's made from materials of the original organism. An example of that would be the vaccine from Haemophilus influenza. So here's a list of vaccine examples and how they're made. We've got several that are made from killed organisms, including Yersinia. Yersinia pestis causes the plague. We've got Bordetella. Bordetella pertussis causes whooping cough. We've got influenza, rabies, typhoid, autogenous vaccines. These are all made from killed organisms. Okay. We also have attenuated vaccines. These are made from altered live agents, and that would include vaccines such as measles, mumps, smallpox, polio, and rubella. Then we have the toxoids, or we have vaccines that are made from toxoids, which is an exotoxin that's been treated with heat or acid and stimulates immunoglobulin production. We've got examples listed as diphtheria, botulism, and tetanus. These are all Clostridium species. And then finally, we have the vaccines made from fractionated material. This is a vaccine made from parts of the original organism. And some examples of fractionated material vaccines would be Streptococcus pneumoniae, hepatitis B virus, Haemophilus influenza type B, and human papillomavirus. There's a few classes of immune disorders that I want to discuss in this lecture. These would include the hypersensitivity disorders, the autoimmune disorders, and the immunodeficiency diseases. So let's get started. Let's talk about hypersensitivity disorders or diseases. Let's first start with the background. When you've been exposed to an antigen a second time and it reveals the existence of sensitization, when evaluating how much time it takes to have a reaction, we term it delayed or immediate hypersensitivity. Okay, immediate hypersensitivity is antibody mediated, and delayed hypersensitivity is cell mediated. So a little bit of a background on hypersensitivity. The degree or severity of a hypersensitivity reaction can be mild to life-threatening. The source of the antigenic exposure is not always known. So you could have a reaction to something you're not even sure you've been exposed to. These atopic illnesses were one of the first antibody-associated conditions known to have a genetic tendency. So if you've ever heard of the word atopy, it refers to immediate hypersensitivity mediated by IgE antibody. Now, being sensitized to something is not always a bad thing. There's actually some benefits to being sensitized to something. For example, being sensitized can be good for the host in the fact that it provides immunity. It provides protection against an environmental antigen. And an immunization is good because it's the acquisition of protection by contact with antigenic material. On the flip side, some occurrences of hypersensitivity disorders can be unpleasant to the host. For example, hypersensitivity is a higher immune reactivity or an overload of the immune response. An allergy can have detrimental effects on your immunity. It's all of these annoying things like watery eyes, itching eyes, sneezing. Those are all part of having allergies. Anaphylaxis is a body-wide or systemic effect on mediators released after the antibodies react with antigens. And atopy is a predisposition or genetic link to allergies against common antigens in the environment. It's an allergic reaction affecting parts of the body not exposed to the allergen, such as a rash and things like that. And again, atopy means immediate hypersensitivity mediated by IgE antibody. Okay, so there's some general terms associated with hypersensitivity you're going to want to know. Exogenous refers to antigenic material originating outside of the host, and this would be things like dust or pollen. Endogenous are antigenic elements native to the host, and that would be the case in someone that has an autoimmune disease or disorder. We've got homologous, which is material of a human origin introduced into a different human, and that would be something like a blood product given to another person or tissue transplants transplanted into another individual. And we have heterologous, which is exogenous material or exogenous stimuli from non-human sources. And again, that's something external like pollen or dust. So allergens, they are associated with type 1 hypersensitivity reactions, and these are substances that are generally inhaled, ingested, or injected that cause you to have the sniffles, watery eyes, coughing, sneezing, rhinitis, and things of that nature. Those are allergens. There are 4 types of hypersensitivity classifications, and their names refer to the mechanisms of reaction. So type 1 is an immediate reaction type. Type 2 is a cytotoxic type. Type 3 is an immune complex type. And type 4 is a delayed hypersensitivity reaction. Type 1, 2, and 3 are humoral or antibody mediated, brought about by an antibody reaction, while type 4 is cell mediated or delayed. It's an interaction of lymphocytes brought about by lymphocytes. Some overlapping may occur of these different types. Let's take a look at the similarities and differences of the 4 hypersensitivity types. Okay? Type 1 or class 1 is called an immediate hypersensitivity reaction. This is a reaction that may take 15 minutes to 12 hours for hypersensitivity to occur. This is also known as an anaphylactic type reaction. It is IgE that is produced in response to an allergen. It's the mast cell or tissue basophil, which is the target cell for IgE. Mast cells are common in connective tissues, lungs, liver, kidney, spleen, and heart. No complement is involved in this reaction, and chemical mediators are the modes of reaction. Chemicals like histamine, slow reacting substance of anaphylaxis, and bradykinin. Okay? Some examples of type 1 hypersensitivity would be things like hives that one must get, that's your mast cells that are reacting, bee stings, and hay fever. These are all types of immediate hypersensitivity reactions. In type 2 hypersensitivity, we've got cytotoxic hypersensitivity, where IgG and IgM are both involved. And this is classified by the interaction of IgG and IgM to cell-bound antigen. Red cells, white cells, and platelets are involved. These are the target cells, or the cells that are going to be lysed in this type of hypersensitivity reaction. Complement is involved, and that's what causes the cell to lyse, and the mechanism of reaction is complement. Some examples of type 2 reactions are transfusion reactions, hemolytic immune responses, and hemolytic disease of the fetus and newborn. Type 3 hypersensitivity is immune complex hypersensitivity reaction. And if you're wondering what an immune complex is, it's an insoluble complex when there is an excess of antigen or antibody. These react with complement, and neutrophils release enzymes in response to these and destroy tissues. They are triggered by the deposition of circulating immune complexes in tissue, causing inflammation. There are large immune complexes that are cleared rapidly by the host, but small ones settles in the tissues, causing inflammation. Complement is involved. Immune complexes are the mechanism of reaction, and an immune complex is basically a linking of antigen and antibody. Some examples of type 3 hypersensitivity would be things like serum sickness, glomerulonephritis, and farmer's lung. Usually these immune complexes are deposited in the glomerulus of the kidney, the joints, or the lungs. Okay, let's go ahead and talk about type 4 delayed type hypersensitivity. This is also known as cell-mediated hypersensitivity. So there's no immunoglobulins involved. The class 4 hypersensitivity is moderated by the link between T cells, monocytes, and macrophages. Okay? Lymphokines are the mechanism of reaction, the release of soluble mediators, which is a chemical that can actually act on your immune system. Examples of type 4 hypersensitivity would be things like poison ivy, dermatitis, graft rejection, and allergy skin tests. Okay. Lymphocytes don't recognize antigens of living cells, but are immunologically active through cell-to-cell contact and soluble mediators or lymphokines. So allergens cause type 1 hypersensitivity reactions, and some allergens are things like pollen, dust, dander, feathers, milk, eggs, strawberries, fungal spores. These are things that are generally inhaled, ingested, or injected. And there's a way that we can treat type 1 hypersensitivity reactions, or at least make the symptoms bearable. Number one, we can control the environment. The avoidance of specific allergens that cause the type 1 hypersensitivity, the avoidance of those things will actually reduce your symptoms. So avoid dust, pollen, animal dander, spores, etc. Desensitization is a deliberate injection of a specific allergen weekly with low doses that gradually higher doses are given, usually over 1 to 2 years. What this does is it stimulates IgG blocking antibodies which bind to the allergen, preventing it from reaching IgE on mast cells. And then finally, there's drug treatment. To effectively treat hypersensitivity type 1 varieties, you can use things such as antihistamines, steroids, epinephrine, and theophylline. The second type of immune disorder I want to talk about are autoimmune diseases. There's actually 80 types of autoimmune disorders. Autoimmunity is an immune response against the host's own cells or tissues. In autoimmune disease, antibodies or T cells display specificity for self-antigens. Every immunocompetent individual is at risk of contracting an autoimmune disorder given the appropriate circumstances. There is no single theory or mechanism that has been identified as the cause of autoimmune diseases. There are several factors that can actually influence the incidence of autoimmune diseases, including genetics, age, and exogenous factors. There are various organs and tissues that can be affected by autoimmune disorders, including the cardiac tissues, the gastrointestinal tissues like the stomach and intestines, the brain and central nervous system, and the liver. Let's go ahead and start with the thyroid autoimmune diseases. There's 3 different types, and I'm sure you've heard of at least one of these: thyroiditis, Graves' disease, or Hashimoto's disease. Thyroiditis is usually a condition seen in the females from ages 30 to 50. These folks have an enlarged thyroid, and that thyroid can be firm or hard. Some symptoms of thyroiditis would be fatigue, weight gain, a feeling of fuzzy headedness, or even depression. Okay? It is caused by the antibodies attacking the thyroid. One such antibody is called antithyroglobulin, and it is an antibody that attacks the human thyroid. Graves' disease is sometimes called hyperthyroidism. This is where the thyroid is constantly stimulated. So the patients have a hyperactive thyroid gland, an enlarged thyroid. They have what's commonly referred to as protruding eyeballs, and the patient is overactive, nervous, and they have that enlarged thyroid and protruding eyeballs. And the antibodies to thyroglobulin and microsomal antigens are what's present. So excessive thyroid hormones are produced, and these antibodies, antithyroglobulin and antimicrosomal antibodies, are those that attack the thyroid gland. Hashimoto's disease is a thyroid disease that usually strikes middle-aged females, although it can occur at any age. What is distinctive about Hashimoto's disease is that the patient has a hypoactive thyroid gland. They appear as having extreme fatigue, they're sluggish, they have pale, dry skin, a puffy face, and muscle aches and stiffness. The antibodies produced against thyroglobulin, microsomal, and CA2 antigens would be called antithyroglobulin, antimicrosomal, and anti-CA2. The disease is characterized by a reaction of the immune system against the thyroid gland. The thyroid gland is moderately rubbery and enlarged in this condition. There are two central nervous system autoimmune diseases that I want to talk about today. One is called multiple sclerosis, and the other one is myasthenia gravis. Multiple sclerosis presents with a partial loss of vision and loss of muscle coordination. This is sometimes referred to as facial palsy. They have lesions of the central nervous system, and that is, those lesions consist of monocytes, and they destroy the myelin sheath of the nerves. The antibodies formed are antibodies against the myelin basic protein. Lab tests reveal that there is a decrease in T cells, an increase in B cells, an increase in IgG levels, and that's seen in cerebral spinal fluid. There is a new theory that was released in 2013 that multiple sclerosis may actually be triggered by Clostridium perfringens toxin. Myasthenia gravis presents as a gradual progressive weakness of the striated muscle. It's usually the ocular muscles that are affected. The ocular muscles affected are facial, pharyngeal, and skeletal muscles as well. The IgG antibody is the class involved in this disease. These people present with weakness and fatigue due to neuromuscular dysfunction. The antibodies formed against proteins present in the muscles, so muscle contraction and strength are impaired. Patients also have an enlarged thymus. The gastrointestinal autoimmune diseases are many, including pernicious anemia, ulcerative colitis, gastric atrophy, and Crohn's disease. These are all considered autoimmune diseases of the gastrointestinal tract. Pernicious anemia is one associated with inflammation of the gastric mucosa. Patients that have pernicious anemia have the inability to secrete hydrochloric acid, intrinsic factor, and pepsin. Intrinsic factor is the substance found in gastric juice which makes the absorption of B12 possible. So if you have pernicious anemia, you're not able to absorb B12. The antibody formed is anti-intrinsic factor. Ulcerative colitis presents as an inflammation of the mucosa of the colon. Diarrhea and fever and dehydration are common symptoms of ulcerative colitis. Antibodies are formed against the epithelial cells of the intestine, and it is the IgG class of antibody involved. In 2016, there was a famous article that suggested that Mycobacterium avium led to Crohn's disease, and a vaccine may actually eradicate it, which is pretty impressive. This brings us to the liver autoimmune diseases, including primary biliary cirrhosis, a chronic impairment of the bile excretion. Bile ducts are progressively destroyed. The second liver autoimmune disease is chronic active hepatitis. This is a chronic impairment of bile excretion. The bile ducts are progressively destroyed. There's also a couple autoimmune disorders associated with the skin, including pemphigus and vitiligo. Pemphigus or pemphigoid is an autoantibody disease that attacks the glue that holds the skin together. This is a blistering skin disorder where the patient presents with big red blisters and the antibodies are formed against the epidermal cells. In vitiligo, this is a condition of skin depigmentation. The depigmentation and pigment-producing cells are destroyed. The treatment for this is steroids, photochemotherapy, and 40 to 50 million people have this disorder. There's a number of connective tissue autoimmune diseases. Autoantibodies are specific for nuclear antigens. The antibodies are formed against components of a cell nucleus. This happens in things like systemic lupus erythematosus and also scleroderma. Rheumatoid arthritis is another connective tissue disease. The antibodies are associated with connective tissue diseases, and they are called anti-nuclear antibodies, also known as ANAs. Any immunoglobulin class can be involved, and the antibodies are formed against various components of a cell's nucleus. Lupus, or systemic lupus erythematosus, is an inflammatory disease that destroys collagen, which binds to capillaries and small blood vessels. It's a chronic disease which may have periods of remission. Some symptoms of a person with lupus would be fever, tiredness and joint pain, small ulcerations on the fingertips, pleuric pain, and nausea and vomiting. Like I said, it is a systemic disease. The collagen is destroyed, which binds capillaries and small blood vessels. It's sometimes seen on the face as what's known as a butterfly rash. And the most prone people to get systemic lupus erythematosus are 10 to 40-year-old females. It is a chronic disease of the T cells. Here, damaged white cells release nuclear material which is engulfed by the LE cell. The LE cell can be seen sometimes on a peripheral blood smear. Serum in SLE contains anti-nuclear factors. Patients end up succumbing to renal failure due to deposited immune complexes in the glomerulus of the kidney. Let's talk a little bit about anti-nuclear antibodies and anti-double-stranded DNA tests. Anti-nuclear antibodies are antibodies directed against components of a cell's nucleus. Anti-nuclear antibodies can be seen in lupus, rheumatoid arthritis, and scleroderma. They can be detected by observing fluorescence of nuclei. Human or animal epithelial cells or tissue cells are used for the ANA fluorescing patterns. Cryptidia, a protozoan, is used to detect double-stranded DNA. This organism contains an intracellular organelle, the kinetoplast, which is rich in double-stranded DNA and lacks other nuclear antigens. So if you have a patient with lupus that has a lot of anti-double-stranded DNA, it's going to link up with Cryptidia, kinetoplast, and fluoresce using a fluorescent microscope. So here we can see human epithelial carcinoma cells, and what is fluorescing in each of those images is the nucleus of those cells. And depending on the pattern that the nucleus will fluoresce, that is suggestive of certain autoimmune diseases. For example, the top left image, the entire nucleus is fluorescing, so that's called a homogeneous pattern. On the top right, this is called a speckled pattern. On the bottom left, this is called a nucleolar pattern, and on the bottom right, this is called a peripheral or rim pattern. So depending on the pattern that the human epithelial cell stains, it'll tell you what disease the patient has in terms of autoimmune diseases. So for example, if you have a homogeneous pattern, your patient may have lupus. If you have a speckled pattern or a nucleolar pattern, your patient may have rheumatoid arthritis. Those are just examples. Let's go ahead and talk now about the immunodeficiencies of B cells. I first want to talk about a condition known as agammaglobulinemia. This is sort of a general condition where an individual has periods of time where they are unable to produce antibodies. For example, babies have periods of time where they don't synthesize immunoglobulins. That would be called a period of agammaglobulinemia. A specific type of agammaglobulinemia is called Burton's X-linked agammaglobulinemia. And this is a condition that's apparent at about 6 months of age. It's congenital and mostly goes from mother to male children. However, once in a while it is transmitted from mother to female children, although that's rare. It's almost always seen in males. These children have multiple bacterial infections such as Haemophilus, Streptococcus, Staphylococcus, and basically anything that can cause a respiratory infection. Their T cells are okay, but their B cell populations never mature in these populations, or they can be absent in the bone marrow and the lymphoid tissues. Common variable immunodeficiency disorder is seen in 20 to 30-year-olds, and it occurs equally in males and females. The immune system appears normal early in life, and this is a later onset disorder. One or many of the immunoglobulins is absent or severely decreased. Patients are prone to sinus and pulmonary infections. They also can have bouts of diarrhea and autoimmune disorders. They're also more prone to Giardia protozoan infections. They have normal B cell counts, but they fail to become plasma cells, and this is related to the excessive number of T suppressor cells. T suppressor cells essentially downregulate other T and B cells. The treatment for this disease is immunoglobulin replacement therapy. The most common B cell disorder affects 1 in 800 people, and that is secretory component deficiency. That's where they have a deficiency of secretory IgA. This condition may actually evolve into common variable immunodeficiency. This is associated with allergies, pulmonary infections, and autoimmune diseases. Generally, these people are in ill health. The patients often have rheumatoid arthritis, lupus, and thyroid conditions, but the patients are no more susceptible to viral diseases. The B cells in this case are unable to mature to plasma cells. Otherwise, they're directed to produce secretory IgA. A monoclonal gammopathy is characterized by a very increased set of one type of immunoglobulins, and the T cell response is also suppressed. It's an uncontrolled proliferation of a single clone of plasma cells. This leads to the synthesis of elevated quantities of one antibody, and all other antibodies will be decreased. This is typical for most immunoglobulins go down, and it's also typical T cell responses are dysfunctional. Some monoclonal gammopathies would include diseases such as multiple myeloma, Waldenstrom's macroglobulinemia, and cold agglutinin disease. So let's go ahead and talk about multiple myeloma in the next slide. Multiple myeloma is also known as plasma cell myeloma, and there's an unknown cause for someone to develop multiple myeloma. Could it be radiation exposure? Could it be viral exposure? These questions remain unanswered. These are plasma cell tumors that form in the bone marrow. The bone marrow cells are replaced with plasma cells. And in normal bone marrow, we have about 1% plasma cells. But in people that have multiple myeloma, their plasma cells can be up to 90% in the bone marrow, and they can actually be malignant. So these tumors erode the surrounding bone, and fatalities usually occur as a result of renal failure or septicemia. Usually that's about 1 to 3 years after diagnosis. A polyclonal gammopathy involves several clones of plasma cells. You're going to see an increase in more than one immunoglobulin, and they can be heavy or light chains that are increased. Results from a secondary manifestation such as chronic liver disease, such as hepatitis B, chronic infections, and even autoimmune diseases such as rheumatoid arthritis. This is not as common as a monoclonal gammopathy. The way that we would identify a polyclonal gammopathy is through a process known as serum protein electrophoresis. Let's go ahead now and talk about a primary disorder of the T cells. Probably the most famous disorder of T cells is acquired immune deficiency syndrome, or AIDS. These people have excessive destruction of their CD4 type T cells, and that's usually their T helper cells. The patients are prone to opportunistic infections such as pneumocystis, pneumonia, cryptococcus, and Kaposi sarcoma. Severe combined immunodeficiency syndrome is a term for a congenital disorder where part or all of the immune system fails to work properly. This essentially describes deficiencies of both T and the B cells. Some examples of this would be Swiss type A gamma globulinemia, Wiskott-Aldrich syndrome, and ataxia-telangiectasia. The Swiss type A gamma globulinemia is a very serious congenital disorder that affects 1 in 100,000 people. Most die by the age of 2. It is an autosomal recessive gene malfunction, and these patients have persistent candida infections. Often this is the earliest sign of the disorder, and it can be seen as early as 1 month of life. People that have Swiss type A gamma globulinemia are more prone to get CMV infections and pneumocystis infections. Their thymus is underdeveloped, and their other lymphoid tissues are underdeveloped as well. They have no lymphocytes or plasma cells in the blood or bone marrow, and the cell-mediated immunity is absent. A bone marrow transplant from an HLA identical sibling may correct this defect. Wiskott-Aldrich syndrome is a syndrome that affects male infants, and it's usually fatal by the age of 10. This is an X-linked associated thrombocytopenic disease. Patients that have Wiskott-Aldrich syndrome have increased bleeding. Usually that's because they have thrombocytopenia or low platelets. They have an inability to respond to polysaccharide antigens. So in other words, they can't respond immunologically to bacterial antigens. So they have increased infections, both bacterial and viral. Their IgM levels are low, even though their IgG levels are normal or even increased. They have no ABO blood group antibodies, and their T cells are decreased, and also IgA and IgE are increased. IgM is decreased. Most of the people that have Wiskott-Aldrich syndrome will develop autoimmune diseases and malignancies. Ataxia-telangiectasia is a neurodegenerative inherited disease. Ataxia means loss of muscle coordination, and telangiectasia means dilation of the small blood vessels. This is essentially a disturbance of gait and posture. So in other words, they have a hard time walking and keeping their balance. They have superficial abnormalities of the blood vessels. Their IgA and secretory IgA are abnormal, and so that makes them at higher risk for respiratory issues. Injections of IgG may help this disorder. Lymphocytes are decreased, IgM is increased, and IgE is decreased. And like I said, these people are more prone to chronic respiratory infections. So this brings us to the end of another lecture. Hopefully you enjoyed the material on immunology. We did discuss our first line of defense, which are body systems and components that help us prevent infection. We discussed our second line of defense, which is the second line of defense, which is phagocytosis and inflammation. And we talked about our third line of defense, which is production of antibody. We also talked about some autoimmune diseases, hypersensitivity issues, T cell disorders, and B cell disorders. So if you have any questions, feel free to reach out to me. Have a great day and a great week. Bye.